today we are in session 4. And as before, we are going to start off with some housekeeping. There's a link for the resources which are available for handouts. For those who are joining us for the first time, there are previous videos available, which you can easily get access to. The feedback forms, please make sure that you fill them up for us once you have attended the session. And of course, there's e-certificates for those who come to us for the 8 sessions. And the 9th session, which is an extra one, is going to be all about Q's and A's from previous talks and MCQs. So questions from the last session were very much about kindly explain the role of lactate in ABGs. Why lactate in ABG? Well, lactate is, we have identified that it's an independent predictor of mortality. And it's a marker for cellular stress. And so, and for some time, actually, it was also a resuscitation target for the sepsis guidelines. Given all those things given together, it has become an essential part of ABGs whenever they are being assessed, because ABGs are not just looking for oxygenation. They're also looking for indicators of biochemical abnormalities, acid-base disorders, and looking for how much the physiological function might have been deranged due to any given condition. And lactate becomes an essential part of that assessment. And I hope that answers the question.
Mohsin, you might want to tell them the normal level and that it's normally produced, but then not cleared adequately in sepsis.
Fair enough. So yes, lactate is made normally by all cells. The biggest source of lactate physiologically actually is the lung. But the liver is the one which is most commonly involved with clearing what the lactate is generated. And sorry, what was the other thing you suggested I tell them?
No, I just said the normal level that, less than 1.5, I think, or less than 2 in some labs. Yeah.
So
it's normal.
Yes. So that is correct. Repeat the chest X-ray findings. Okay. I think I'll wait for Dr. Jaffer, and if he can't answer those, then I'll try to answer those before the session ends. Nasal cannula, you can give up to 6 liters per minute of flow through a nasal cannula. Just keep in mind that any flow beyond 4 to 5 liters leads to drying of the airways. And so you should be actually thinking about escalation to a different device rather than just going to the maximum flow rate through the cannula. ABGs don't include FiO2. How can we measure it? FiO2 is kind of an important part of how you should assess ABGs. So I'm not entirely sure what the question means.
I think what they mean is that the ABGs, they don't tell us the FiO2, but that is FiO2 is something that we decide when we know, and we are supposed to report it with the ABGs. That's how our ABGs are reported. So if you have a patient on 50% oxygen, your ABG, your respiratory technician or whoever ran the ABG should tell you FiO2 is 50%. That should be part of your report.
Yes. Well,
that's something that we said here.
Fair enough. And kindly explain pancreatic syndrome.
Yeah.
Okay, I'll let Dr. Jaffer explain it in simple terms because I don't think I can.
Yeah.
Having said that, we will recap what happened with Mrs. N. This is the lady, as you remember, who initially came to us with what was thought to be diabetic ketoacidosis, and while with us in hospital, developed tachypnea, tachycardia, became hypoxic, and on the last session, we had concluded that she had developed ARDS. Along with that, we had identified that she would not be a candidate for awake proning or CPAP, and that we needed to move on to intubation. And so here we are, off to Dr. Kalim, who will take you through invasive ventilation.
Assalamu alaikum. Can you hear me?
Yes, we can hear you good.
Yes.
Okay. So as you guys been learning about how to take care of the patient who are sick, especially developing pulmonary problem, today discussion is going to focus on how to ventilate the patient when the person is not able to breathe and sustain oxygenation and ventilation by themselves because of the illness. So this is the topic of the day. What I'm going to do today is I'm going to go over with the definition of this, what are the indications, briefly talk about the different ventilator setting and how we do it. And then we talk about modes of ventilation. What are the different types of parameters we could set on the ventilator to assess our patient? And by doing this, as we know, anytime we do any intervention, there's always some kind of risk involved. So we're going to talk about some risk associated with this modality of the management. And then again, we touch base with how we set different ventilator setting. And then Shabana is going to be taking over and talking from the nursing perspective about the nursing care related to the ventilator, and then we summarize that thing. Now, before I proceed, next slide, please. Mechanical ventilation primarily is to provide or augment required patient breathing requirement. And what are the patient breathing requirements? Anytime we breathe, we need to get air with the oxygen in it into our body, and then body uses energy, and during the process of making energy by the food product which we eat, it creates some byproduct and a waste product, and it is a form of the carbon dioxide, and that need to be come out. So mechanical ventilation is primarily a machine designed to help patients when they are unable to do the routine thing which we do on a regular basis, to bring the oxygen into the lung and take the carbon dioxide outside the lung. So this is the function of mechanical ventilation. Now, whenever we talk in medicine about the mechanical ventilation, people think that mechanical ventilation is something which is very extraordinary thing. And it is sometimes intimidating, not only for the nurses, not only for the medical student, but also for the physicians and people who are not accustomed to use this. So our responsibility is today is to give you some outline in a way that you feel comfortable be around mechanical ventilators and understand it briefly. Now, next slide, please. So this is some kind of cartoon showing that a patient who is in ICU, and there are many different tubes are attached. There's different devices are there. And basically it is showing what our usual patient in ICUs look like. Now, before I proceed, mechanical ventilator, it is a machine. Like any machine, we need to learn how to operate it. And we need to know what exactly the purpose of this machine is. So what machine does, why we use it, and how to use it. For a simple example, most of us know how to drive a vehicle, whether it's a bicycle, a motorbike, or car. For the safety of that, anytime we try to initiate a drive, we need to know where the ignition is, how to start the car, what are the things required for the car to function properly, whether there is tire pressure is okay or not, is my rear view mirror is functioning fine or not, whether I have enough gasoline into my tank or not. So all these things are important for car to do its job, which is taking us from point A to point B. And this is the purpose of a vehicle. Vehicle could be many different type and form and shape, and could be very simple or could be very complicated. But the purpose is that it take you from point A to point B. The job of the mechanical ventilation is when the person is sick and unable to do the proper breathing, which is we all need for sustaining life. This device helps us to get over this acute critical condition. When the body heals itself during that time, this device provided breathing and sustaining our function of breathing. So this is the only purpose of that. But to do that, there are certain kind of things in the machine, and we need to simplify that thing too so that you could understand. Next slide, please. So the origin of mechanical ventilation. So mechanical ventilation started from initially as a negative pressure ventilation. And nowadays we don't use negative pressure ventilation, we use positive pressure ventilation. So let's talk briefly about what is negative pressure ventilation is. It is, in a layman term, it's used to call as iron lung. What happened is that initially it was started as a non-invasive ventilation, first used in Boston in 1928, and is primarily mimicking the normal breathing pattern. So if a person breathes, what we do, we try to initiate a breath. That initiation, although we are not aware of that because it is mostly a passive action, but on a very cellular level, when we initiate a breath, we create a slight negative pressure by expanding our chest and moving the diaphragm. That negative pressure open up the airflow through the glottis into the lung. So by expanding the chest, air moves from the atmosphere into the lung. And that is a negative pressure breathing, which we do all the time. This device was created in a way that is put around the chest and then create a negative pressure artificially so that the person can breathe negatively. Now, it was used massively during the polio outbreak. And then later on, it was, the positive pressure ventilation was initiated. This is the positive pressure ventilation where instead of body creating a negative pressure artificially, the machine deliver force air into the chest. So that's the reason it's called positive rather than negative pressure ventilation, because we are introducing air into the lung with a force. Next slide, please. So there are question mark. I think what we used to call is a loss in translation. It was made in some different way, and now because of the different format, there is no question mark here. This is just a bullet point which is translated into question mark. So ignore about that, please. So positive pressure physically transports. I already told you about that it physically transports the gases or air mixture into the lung. And for doing this thing, most commonly, we do it through invasively. And what does it mean by invasively? We put a tube, which is endotracheal tube, through our mouth or nose into the trachea, and then attach that device machine to deliver the desired amount of the gas or air. But it also could be done non-invasively, like you all know, there are devices which we use as an interface rather than ET tube. We use a mask and then machine attached to that, and that's called non-invasive ventilation. Next slide. So the principle of ventilation, this slide, I think you guys have, last lecture, I saw there's a lot of discussion about different zone of the lung and what is the optimum area of the lung where the ventilation perfusion is optimum. This is basically trying to show you the same thing. And I'm not going to go into detail. Primarily, I want to focus on that in zone 1, this is usually a dead space, and zone 3 is generally as a shunting part, because in zone 1, there is more air ventilation, air is going, and the less amount of the blood flow because of the gravitational changes. And then zone 3, where there's a maximum amount of the blood flows goes there, but the amount of the air going into the alveoli are mismatched. So that's the reason sometimes it doesn't touch the inflated alveoli, and the air blood passes through without seeing the oxygenated air in the alveoli. So minute ventilation is a term. I want to go over some terms here. So minute ventilation is a term used, the amount of the air we breathe within 1 minute. So each time we take a breath, whether we are doing ourselves or on the machine, that amount of the air which goes into with each breath is called tidal volume. And RR, which is the respiratory rate. So minute ventilation, which is VE, is equal to the number of breaths we take in a 1 minute, multiply it with the amount of the air we breathe in. So when we breathe in any air, it goes into this zone area. So alveolar ventilation, VA, and VD is a dead space ventilation. So what is a dead space ventilation? The area where the air is there, but it is not participating in transportation of oxygen and carbon dioxide in the lung because of the zone distribution. That's called dead space ventilation. Whereas and then we calculate a ratio between the dead space and the tidal volume, and generally it should be less than 0.33, which is, if this is less than 0.33, it means that the lungs and everything else is functioning okay. But leave it there for further discussion in detail, and then we'll talk about pure mechanical ventilation, different mood in this topic. And then the amount of the air we breathe in 1 minute, or respiratory rate, is basically governed by the brainstem responding to our internal body pH and tension of the carbon dioxide in our body. Next slide. And again, the oxygen, which is also it's part of the whole equation, is the primary goal of oxygenation is to maximize delivery of the oxygen to the blood. And then we calculate a gradient, and we'll talk about that in detail later on. Next slide, please. So, as I said, it is a supportive measure, not a therapy. So just by putting somebody on a ventilator, we're not going to be able to take care of the patient problem, depending upon what the problem patient has. It is a supportive measure. And we are responsible to figure out what exactly the cause of the problem is and try to do the treatment, initiate the treatment modalities to take care of the problem. And during that time, the mechanical ventilation is used to rest the patient till that underlying disorder is improved. And by doing this thing, hopefully, we are doing in a way that we do not create more harm. As you know, that you can drive a car from point A to point B, but if you're not careful, you may crash it. And you can harm yourself and others. In the case of mechanical ventilator, it is also important that we understand different things which are important to make this device useful in a non-harmful way. Next. So before we put somebody on the mechanical ventilator, we intubate the patient. And what are the different indications for intubation? Depending upon patient condition, if it could be to prevent any kind of obstruction in the airway, to maintain the airway patency, because we need to have patent airway to move the air from atmosphere into the lung. Sometimes people's mental status are compromised because of one or other condition. Either they have a stroke, or they are under the influence of medication, or they are having some kind of poisoning, or they have passed out, they have seizure. So when somebody is not conscious, there is a possibility that they can aspirate the oral secretions into wrong direction and goes into the lung. So intubation prevent this kind of aspiration of the person's own secretion or foreign bodies. The third thing is to provide oxygenation, which is one of the reason if somebody is not able to get enough oxygen through the normal phenomena, this device is going to provide that. And ventilation is the fourth one. In general, ventilation is the term used to get rid of the byproduct of metabolism, which is carbon dioxide, out of the system. So oxygenation provides oxygen, and then removal of the carbon dioxide is going to term as a ventilation. Although when we use mechanical ventilation or ventilation, it comprises both oxygenation and ventilation in general. And then tracheal toilet to get rid of the secretion which is developing within the lung and suction it out so that the patency will be maintained. So there are 4 different things. There is 4 P's, which I call patency, protection, positive pressure, and permeate toilet. Next slide. Again, ignore this question marks here. So improving the oxygenation and improving the saturation of the oxygen saturation in the blood. So mechanical ventilation provided to patient when their oxygen, partial pressure of oxygen is low or saturation is low. Improving, again, the same thing. Reduce the work of breathing. So what is work of breathing? In general, when we breathe, we hardly noticed anything about the breathing. It is a passive phenomena. And we talk, we eat, we sleep, we jog, we walk, and we were not aware that we are breathing, which is an essential function to sustain life. But when the people are sick, their work of breathing is getting harder and harder because either they are unable to get the desired amount of oxygen or unable to get rid of the carbon dioxide. So the body utilizes a lot of energy. Usually the breathing is very minimum energy consuming activity. But sometimes when somebody is very, very ill, about 50% of the energy produced in the body could be utilized just to sustain breathing. So by putting somebody on mechanical ventilation, we try to conserve the energy and reduce the work of breathing. And sometimes people who are hemodynamically unstable, we can also provide a bridge during that time to maintain their hemodynamics. Next. So inadequate oxygenation could happen because of ventilation perfusion mismatch. Again, this has been already discussed before, and I already touched a little bit before, so not going to go in detail. Point is that whenever there is a mismatch because of any different type of condition within the lung, airway obstruction, hypoventilation, if there is a problem of the diffusion of the oxygen from the alveoli into the bloodstream, and that causes inadequate oxygenation, this mechanical ventilation can help that. And then, decreased mixed venous oxygen. Again, this is a concept we're going to talk about in sepsis lecture, but this also could cause the inadequate oxygenation to the tissue level. And then shunting, right to left shunt, when the part of the lung is not able to participate in the oxygen transportation and the blood move from the right side to the left side of the heart without even engage into the act of gas exchange. Next slide, please. So these are the different conditions which can cause the problem with the oxygenation, including pneumonia, aspiration, pulmonary edema, congestive heart failure related, atelectasis of collapse, when the part of the lung is not fully expanding. Lung is like a sponge. You squeeze it and release it, go back to its baseline volume. But in certain scenario where the lung is squeezed or it collapses, it doesn't go back to the normal because of either the obstruction or the filling of the fluid within the alveoli. Many different reasons could cause that. ARDS, we all talk about that in the COVID environment, which is acute respiratory distress syndrome, when there is lungs alveoli are filled with the inflammatory fluid and having problem in terms of oxygenation and ventilation. Pulmonary contusion after any traumas, hemorrhage could occur within the lung, which also can cause problems. So all these things, which is listed above, is causing problem in terms of the surface of the alveoli, where the air is going to be filled, and the capillaries, which is around the lung, to have the air exchange happen. So there is some kind of barrier, physical barrier there within the alveoli, which is making it difficult for air to move in, to diffuse from the alveoli into the capillaries, and then back from the blood into the alveoli, the carbon dioxide. And there's some condition like hemothorax, pneumothorax, and pleural effusion, which is the outside the lung, but it is providing pressure and compression to the lung, and then it is causing the shunting mechanism. Next. So ventilation is primarily to increase the removal of the CO2 from the body, and it's dependent upon the minute ventilation equation, which I already told you, which is the respiratory rate multiplied by tidal volume. So the minute ventilation could be changed on any set patient by changing either the rate of the number of breaths per minute or the amount of the volume of the air which we are delivering through our device. So these are the two variables which basically control the CO2 removal mechanism. Next. So again, this is a repetition. The work of breathing is basically to how to keep up with the CO2 production. Sometimes people like asthma or COPD, when they have airway obstruction, there is a resistance in terms of movement of the air from the atmosphere into the in the lung, and all the resistance is within the tube. So the trachea, the bronchus, and the right and left bronchus till the terminal bronchiole and the alveoli. So all the passages provide the resistance. If there is a bronchospasm, then there is going to be problem in terms of breathing. And you might have seen patients who are having acute exacerbation of either of asthma or COPD, they're bronchospastic, and they are struggling to breathe. And the compliance of the lung is basically the lung compliance, how lungs is, because compliance is primarily a measurement of the changing in the pressure, how much volume is changed. So pressure and volume variability is basically, we measure it on the basis of compliance. So if we put a little bit pressure to a normal lung, the lung is going to expand. And if the capacity of the lung to expand is diminished, we'll call it decreased compliance. But if the lung is like somebody who has a normal lung or has obstructive airway disease, like asthma, COPD thing, their compliance is very high because you put a little bit air, the lung is expand too much. Chest wall is again the same thing. If any kind of problem with the chest wall movement also can restrict the breathing mechanism, and the compliance could be related to chest wall issues. Sometimes there is issue with the abdominal content when somebody has an acute abdomen, increase ascites, some air within the abdominal cavity. There is an increase in the pressure, which is trying to transmit from the abdominal cavity to the diaphragm, and that will cause problem with the compliance too. So increased work of breathing usually related to CO2 problem, but may need when purely just to support the work of breathing. So somebody who has no problem, like in patient with the acute asthma exacerbation, their oxygenation is okay, the CO2 in the stage 2, stage 3 kind of thing means when they are not severely compromised with the bronchospasm, they are fine, but they are breathing very fast and they are struggling to breathe because too much resistance in the airway. So to improve the work of breathing, we sometimes intubate this patient. Next slide. So again, I think we already talked about that. Next slide. So how do we use them? Next slide. So there are mode of mechanical ventilation. So when we set the mode, we like a machine, we need to machine is dumb, although it is very smart, but it is dumb unless we tell the machine what to do. So the mode of ventilation are basically our instruction to machine how they're supposed to help our patient. So the machine could be set as in a spontaneous mode when the patient is going to take full control, or control mode when the machine is going to take over the patient altogether and not allow patient to do anything, or the dual mode when both spontaneous and control mode work together in harmony. And that is what we're going to talk about in this different scenario. So controlled mechanical ventilation, which is sometimes called CMV, it is the earliest form of positive pressure ventilation which have been used. And this mode, we no longer use it, but here I'm mentioning it so that you could accustom to some terminologies. Control mode of ventilation, we set the machine, and depending upon how we are setting, machine control the work of breathing. If we tell the machine to do X thing, it's going to do it no matter what. And it doesn't give any room for patient to do anything above and beyond what the machine has been told. We augment this mechanical mode of ventilation from control to assist control mode, which is a little bit more conservative in a sense that it is giving the little control to the patient as well, and is work as a dual mode of ventilation. So what does it mean? That machine does its job when we provide certain parameter, like say, for instance, we give the machine how many times machine should provide the breath to the patient, and what amount of pressure or volume we're going to dial into the machine. Machine is going to provide that. But in addition to that, if the patient want to breathe.
Dr. Kalim, sorry for interrupting. I'm going to change over so that Dr. Kabani can take over the presentation.
Sure.
And I do apologize for this.
It's okay.
Dr. Kabani? Okay.
Do you have to leave?
I have to leave, sadly, yes.
Oh, okay.
Okay. Let me change. Let me share my screen with you.
Thanks, guys. I do apologize. Thank you.
Yeah. What slide number are you on?
I can tell you. Oh,
because I thought you were waiting till the
it's
MCQ.
slide 22.
Slide 22. Okay. Can you guys see my screen now?
Not yet.
Not yet.
Okay. It should be coming up, I hope. Can you see it now?
Yeah, but you go back.
Fine. Let's go.
Okay. I'm trying to figure out what slide he's on.
22.
Oh, I'm sorry. Okay, because I think I was on 27. That's what I had ready for.
Go up a little bit.
1 second.
More, up more. One more.
Sorry about. Okay, yeah. 1 second. One more. Yeah, this should be the one. This is 22 on my
Yeah,
side.
go up a little bit more. One more.
One more. Okay.
Yeah. I think I have not finished that. More.
Okay, this is good.
No, not more. Up.
Are we going up or down?
Up.
Okay.
Up. Yes. Okay. Good. Yes. Okay.
Okay.
Yes.
There you go. Okay.
So sorry for this interruption, but let's recap. So assist control mode of ventilation is primarily what it is the machine does everything, what we ask the machine to do. But in addition to that, it can assist the patient and allow the patient to breathe above and beyond what the machine was advised to do. And it could be run either in a volume control mode, or it could be run in a pressure control mode. And I'll talk about this thing in the next few slides. And then there is another mode of ventilation, which is called intermittent mandatory ventilation, which is, I use it SIMV because it is synchronized mode. So it could be, it was initially invented as an intermittent mandatory ventilation, but now we have synchronized the machine so that machine can breathe in sync with the patient. So when the patient is going to breathe above and beyond the ventilator setting, then is going to synchronize with the patient breathing pattern rather than automatically on a fixed timing. So it's much more palatable and comfortable for the patient. And then the pressure support ventilation, PSV, where machine just provides certain support to the patient, but it does not provide any fixed rate or fixed volume. Next slide. So like machine, as I said, that it's going to do only thing which we ask the patient, ask the machine to do. So for setting a ventilator, we need to set certain parameters, certain target. And these are the terms which I want you guys to remember and recognize. One is called trigger, other is called target, and third thing is called cycle. These are the three important things which we're going to talk again and again and again. And even in our practical life, when we deal with the ventilator, what is the trigger, what are the targets, and how the cycle is. So what is trigger? Trigger is how the machine is going to know that I have to provide a breath. So who is going to trigger what start the breath? These are the two things. So in an assist control mode of ventilation, machine will trigger the breathing. So machine is dialed in a way that, okay, with a set time, or machine is going to provide a breath. What to start the breath? How the machine is going to sense? Patient or vent? Either the patient is going to initiate or the machine is going to initiate that process. And then we set the trigger by dialing in either some negative pressure or flow pattern. And we'll talk about that in future. But basically here is what initiate the breath and target. What are we trying to achieve? Are we trying to achieve to deliver certain amount of the volume, which is startle volume, with each breath, or we are trying to deliver certain specific amount of the pressure and then let the lung decide how much air is going to move in. So we control either the volume or we control the pressure. And pressure and volume, as I told you before, is interchangeable. And the cycle, when the machine is going to know how to end the breath, because you told the patient machine, so let's start delivering 10 breaths per minute. But how the machine is going to know when should I stop giving the air in, or how should I stop the inspiration, and how the expiration is going to start, because we know that the breathing has two components, breathing in and breathing out, inspiration and expiration. So cycle is the term we use for the mechanical ventilator, that how the transition is going to happen from the inspiration to expiration. And we'll talk in detail in future. Next. So trigger is assist control mode of ventilation. Machine and patient both can trigger, as I told you. Target we could set as a volume. So for example, Mrs. N got intubated, and before we intubated the patient, we decided that because patient is not breathing, we need to dial in some numbers on the machine. So we said, okay, the machine is going to provide 10 breaths, and we set a tidal volume of 500 with each breath. And patient initiate 6 breaths per minute, vent provided 6 breaths. So what does it mean is, first thing here, when the vent is set at 10 breaths per minute with 500 cc, machine is going to deliver, no matter what, this amount of ventilation to the patient. But on top of that, if the patient decide to take extra breath, and suppose the patient is taking here, as is written, that 6 breath extra on top of the 10 breath which we have set on the machine, machine is going to deliver the same amount of the volume with each breath. So no matter what is triggering, the amount of the air delivered with each breath is going to be fixed in a volume control mode. If it is a pressure control mode, for example, we have set a pressure that 35 pressure is going to be delivered. So each breath is going to deliver the same amount of pressure. So no matter what trigger in assist control mode, either the patient or the machine, the amount of the set tidal volume of pressure is going to be delivered to the patient. Next slide. And the pressure control, as I said, the pressure control is machine or patient, again, the same thing. And then if we set a rate of 10 with the pressure of 24, and another term which we use, which I have not talked about, which is called PEEP, which is positive end expiratory pressure. You know, when we breathe in and out, we leave certain air in the lung, and that air is residual volume, which make our alveoli keep distended. So in an artificial mode of ventilation with the ET tube and put the machine, we try to dial in certain numbers so that the alveoli remain open after the end of each breath. And that is the thing which we call PEEP. And we can change this thing on the machine as well. So for instance, we put a pressure rate of 10 with the pressure dial in at 24. And then we dial in the FiO2, which is partial pressure of oxygen, 0.5, and PEEP of 5. So the machine is going to deliver the same amount of the breath, 10 breaths per minute, at a pressure of 24. We add that 24 pressure to the PEEP, it's going to be 29. So the peak airway pressure in the machine, which each breath is going to be controlled as 29. If the patient decides to take an extra 6 breaths, as it did in the volume control, the machine is going to deliver the same amount of the pressure as I told you before. Next. The synchronized intermittent ventilation is slightly different than assist control. It's almost everything is the same as far as the trigger and target setting is concerned. The only difference in this mode, or SIMV, or synchronized intermittent ventilatory ventilation, is that when the patient decides to take an extra breath on top of whatever we have decided machine to deliver, for instance, here the rate is 10 and tidal volume of 500, FiO2 of 50% and PEEP of 5. This is what we have dialed in. Machine is going to give, no matter what, this amount of thing. But if the patient decides to take extra 6 breaths, this time, the amount of the air is going to move with that patient trigger breath is going to be variable. It's going to be depending upon how much strength the patient negative pressure is to get tidal volume. So it could be 150, 250, 450, 600, 800, depending upon the compliance of the patient, how the lung is either stiff or it is compliant. Next slide, please. Pressure support ventilation, on the other hand, is pure dependent upon patient effort. So the trigger is only by the patient, and target is the pressure, whatever we decided to dial into the machine. And the cycle, again, this concept which is coming, how this machine is going to decide when to end the inspiration is the patient flow decrease. So most of the time, if there is a 25% decrease in the peak flow during inspiration, machine decide, okay, this is enough because we have dial in there. The machine is going to switch from inspiratory mode to the expiratory mode, and the expiratory port is going to open, and the machine is going to go into the expiratory mode, and patient is going to breathe out. And completely unassisted breath, like the CPAP, it is not a mode of ventilation. It's some primary we use sometimes to assess the patient, whether patient would be extubated and being off. And then we just provide the FiO2 and the PEEP on that. So if in this kind of mode, if the patient is breathing, all the amount of the number of the breath is generated by the patient, and the amount of the tidal volume is also depending upon patient effort and the compliance of the lung. Next. Question.
Go ahead. Question number 1, and you have about 30 seconds to answer that. So basically the trigger for the volume control is the patient only, the ventilator only, for patient and ventilator, or no trigger? Do we have any answers? Oh, it says host and panelist cannot vote. Okay, that's fine. We are not voting.
Yeah, we are not, okay.
Do we,
Fair enough.
Khalid, do we have the answers?
We do have the answers. Sorry, I came
you're
back.
here.
I've just come back. Yes.
Okay.
It turns out that 71% thought it was patient and ventilator, but 20% thought it was ventilator only, and 8% thought it was patient only.
So let's me take over from here. So what it means is that I am not clear. It means the teacher is not good. That's because it's a very simple thing. Because these are the very simple concept. So let's go back on this. Trigger on volume control, assist control ventilator, as I said, it is both patient and the machine can generate. The only difference here is that whenever somebody is going to need a breath, machine is going to deliver the same amount of the target which we have set in. Like say we have set a tidal volume of 500, trigger is going to initiate it by the patient, machine is going to dump 500. If it is patient is not triggering, machine is set a rate of, let's say 10 breaths per minute, machine is going to deliver 500 cc. So in a volume control, both patient and ventilator can trigger. Ventilator only, the B, it is for the obsolete mode of the ventilation, which is the control CMV. And in that time, or somebody is paralyzed completely and patient cannot initiate, then that thing can happen. Okay, next question. Now, the trigger for pressure support ventilation, PSV, is A, patient only, B, ventilator only, C, patient and ventilator, and D, no trigger is needed. Again, 30 seconds, right?
Can you see the results as they're coming on?
I could not see. Where should I see?
I'm not sure why not. I can see them, so I'll share them. Again, 42% thought patient only, 21% thought ventilator only, and 29% thought patient and ventilator, and 8% thought no trigger is needed.
Dr. Kalim, you have done a very poor job.
Let me mute myself.
Okay, so let's go over again here. The trigger for pressure support ventilation. Pressure support is a mode of ventilation when machine only provide certain pressure for the patient to help breathe in. And it is triggered only by the patient because we don't dial any rate on this mode of ventilation. We do not dial any tidal volume on this patient. We do not dial any time for patient to breathe in and out. It is purely driven by the patient effort. So if the patient is not going to initiate a breath, machine is not going to provide any breath to the patient. That's the reason when Shabana is going to talk about different alarms, we'll see how we safeguard this mode of ventilation in patient where we are concerned about that the patient is not going to initiate the breath. So again, the pressure support ventilation is primarily a patient-driven process. Ventilator play only a supportive role depending upon what pressure setting we put in so that the flow goes into the lung. That when it reaches certain preset pressure setting on the ventilator, the patient get it, and then patient decide how to exhale on the basis of the flow. Next slide. Which of the following modes of ventilation does not allow the patient to breathe above the ventilator setting? So again, there are 4 choices. The CMV, which is controlled mechanical ventilation, SIMV, synchronized intermediate mandatory ventilation, AC, assist control mode of ventilation, and PSV, pressure support ventilation.
Hi. So we got the results again, and
Yes.
61% have said CMV, sorry. 28% thought SIMV, 6% thought assist control, and 6% thought pressure support.
Okay, so let's go again briefly here about again. This is a phenomena where the ventilator does not allow. The word is allow. No matter what you do, you're not allowed to do anything else. So it means the ventilator take over everything. You cannot do anything. So that's the only mode of ventilation, which is the CMV mode of ventilation, because SIMV, by its definition, synchronized intermittent mandatory ventilation. So something is intermittently synchronized with the patient effort. Assist control, as its name said, is assist the patient to breathe over the machine setting. And pressure support, as we talked about earlier, that it is only driven by the patient. The machine is only providing a support to attain that dial in pressure. Next slide, please. So let's talk about a little bit about, am I too slow or I'm okay?
You're a bit, if you can hurry,
Quickly, okay, I got it.
Yeah.
So adverse effect of mechanical ventilation, as I said, that this is a machine and the safety is very important. So when we do some intervention, we need to be careful about how to monitor and avoid any kind of complication. So there are many complications could happen with mechanical ventilation. The pulmonary complication, it could be associated with intubation itself. Like when we intubate, we have to be careful about, make sure that we are not causing trauma to the oral cavity, teeth, soft palate, vocal cord, because we are introducing some kind of force by the process of intubation. We are using the laryngoscope, different type of variety of that, and we're putting in the ET tube, and all these things can cause trauma. So we have to be mindful about that. Air leak from the, if you put the ET tube, you know that we have ET tube with the cuff, and the cuff has is to seal the ET tube around the your trachea, so that the secretion from the oral cavity could not go into the lung. So if that is the air leak happened from the cuff, then that barrier is going to be compromised. Ventilator associated lung injury. This is a big topic. When we ventilate the patient, we are doing is positive pressure ventilation. We're pushing the air. So knowing our limitation, knowing the physiology of the lung, knowing what harm could happen if we are not careful, that may cause different kind of abnormality in the lung parenchyma, and that creates problem and the safety issue and sometimes bad outcome in patient care. And dynamic hyperinflation, basically if somebody has bronchospasm, if you are doing certain type of mode of ventilation when the patient is getting breath after breath, air comes in, but because of the bronchospasm, air cannot go out. The inspiration is there, but expression is prolonged. You have seen patients with the COPD or asthma, when they breathe, they wheeze. The wheezing is basically that the expression is prolonged. So they take a lot of time to all the air from the lungs to come out. But if we compromise the amount of that time, which is required by the patient to breathe out, and the machine is giving set breath again and again and again, the extra air is going to get into the lung and that cause hyperinflation, and that cause auto-PEEP, means the PEEP is going to be up, increase and expiratory pressure is going to be artificially up. Next slide, please.
Dr. Kalim, you've got 3 more minutes for your part of the talk.
Okay, got it. So cardiovascular complication, hypotension, increase CVP, decrease venous return, and increase right ventricular outflow. What exactly, all this could come from, summarize in a way that because it is a positive pressure ventilation, we put extra air into the lung. When we breathe normally, we create negative pressure, and that's the reason the air moves in and out of the lung. But in the mechanical ventilation, we push positive air. So the pressure in the intrathoracic cavity increases. You know, the heart sits in the middle of the chest. So this extra pressure can be transmitted to the right ventricle, and it increases the pressure on the right ventricle. Blood flow from the body goes into the right ventricle on the basis of the pressure gradient. The lower pressure in the right ventricle, higher pressure in the circulation, there is no problem. But if we increase the pressure on the right ventricle, that causes compromised return of the blood into the right ventricle and to the ultimately to the left ventricle, and that causes the cardiac output to decrease, which causes hypotension, decreased venous return, and increased afterload because of these whole phenomena. If the patient is on ventilator, there is chances of GI compromise with ulcer and then GI bleeding could happen because of the stress. Next. Again, the CNS issue, increased intracranial pressure could happen because of the same venous return related issue and some other biochemical markers which happen because of the over-distended of the lungs. We're not going to go into detail. Prolonged sedation, when we put the patient on the ventilator, we sedate the patient so that patient and machine can breathe in synchrony. But if we do prolonged sedation, that could cause problem. And if we sometimes when the patient is not cooperating with the machine because of the patient-machine dysynchrony, we have to paralyze the patient and let the machine take over so the patient could not breathe in between. So neuromuscular blockage can cause myopathy and neuropathies in the clinical condition. Next slide, please. Okay, so now take a deep breath. I'm done here. And Mohsin, take over from here, please.
Yes. Thank you, Dr. Kalim. That was a wonderful chat, a wonderful talk. And what we are going to now go ahead and focus on is the practical aspects of all the things that you have learned from Dr. Kalim earlier today. So take a deep breath. And while you do that, Shabana is going to take over and start from there.
All right. Assalamu alaikum, everybody. Yeah, so I'm sure you still are taking long, deep breaths because what I'm going to talk about may need this exercise again and again because I want you to visualize what I'm trying to explain, okay? So Dr. Kalim has very nicely explained about different modes of the ventilation. And all I can say, when I was a nurse at the bedside, these concepts are a little bit difficult sometimes to understand and memorize, but as you go on and learn and read more about them, you will be able to understand what these modes are all about. So as he said, the control mode, everything is controlled. Everything is the machine. No patient is involved. So everything has been taken over by the machine. And then as he mentioned, the assist control means the assistant, like half patient, half machine is helping. And synchronized SIMV, a little bit ventilator is giving a little chance for the patient to breathe in, but not providing that much luxury to the patient. In assist control, the machine is giving the volumes, the pressure, everything to the patient. But in SIMV, if patient will take the breath, he will get the less number. If machine will give the breaths, patient will get more. Just remember this way. And the pressure support, no ventilation, all is patient and patient, okay? So from there, since we have already discussed the mode, let's discuss the ventilator parameters. The ventilator settings or parameters are used to achieve the required tidal volumes and the minute volumes, and we can keep the oxygenation in the body and can remove the excessive carbon dioxide. So as we mentioned that we have a set machine and we have just pushed the button for this mode or that mode, but it's not going to work like that. You have to set some limits, some parameters for that machine to operate or to understand, okay, what does that mean? Okay. So the first one is the respiratory rate, very self-explanatory, how much rate we want the machine to breathe, how much respiration we want the patient to breathe in. That includes the ventilator, not the patient, because we cannot control patient should take just 5 breaths or 7 breaths. No, we want a controlled breaths only from the ventilator. If we want more breaths, we need to set up higher. If we want machine to take less breath and let the patient breathe more, so we will make it to a little bit lower. Okay. The second one is tidal volume. Now, you just took a very deep breath. What is a volume? Volume is how much amount of air is going inside your lungs. So if you take a deep breath all in, now see how much air went in your lungs. That is your volume, the amount of air you took in. And while I'm talking, I'm exhaling out as well. That means I'm taking all the air out from my body. So that's simply the tidal volume. So it's just the deep breathing capacity of the lung. Okay, you in or you exhale. If you inspire, it's your inspiratory tidal volume. And if we exhale, that's your expiratory tidal volume. Okay, so whatever amount goes in, comes out. A little bit remain in the lung to keep our alveoli open. So usually this is set for like 6 to 8 ml as per the body weight. And the body is not something, say if I weigh 100 kilograms, so my body, the tidal volume will be set as per the that weight, because your body grow, not your lungs. Okay, so we just keep an ideal body weight and we keep all the setting according to the ideal body weight. So next is minute volume. So minute volume simple is just like number of breaths that we are taking, and then multiply with the tidal volume. Say we set the tidal volume of 400. We want the machine to give an amount of 400 ml of gas or oxygen or air to the patient. So you multiply 15 by 400, that will give you 6,000 ml or 6 liter minute volume. So this is how we calculate how much total volume we want the patient to get. Then comes the pressure support. And as Dr. Kalim mentioned, that pressure support is something that you are giving a little bit pressure to support the patient to breathe in. Remember those days when we used to buy balloons and those telawalas used to put the balloons on some kind of a machine or cycle, and with that, they will blow the balloon. So what is that little knob, this pressure, right? You set up the pressure to help the air rush in the balloon, so balloon could inflate more. So this is what the same concept goes in the pressure support. You give a little bit pressure, so the more volume can go in the patient's lungs. So by giving more volume, you are giving more oxygen to the patient, okay? And that comes to FiO2. FiO2 is what? How much oxygen you want the patient to have in the body. We always start with 100% when we intubate the patient, but then we gradually goes down. So how much oxygen you want the patient to get, or it's mentioned in FiO2, which F is like a little F with that. If you see on the ventilator screen, you see it's with a little F that would say the FiO2. Okay, so of course, in the ARDS patient, like what we have in Mrs. N's case, we may need more FiO2 to compensate because she is not able to maintain those oxygenation in the lungs. The other thing Dr. Kalim just mentioned about P, positive and expiratory pressure. So what is that? As we all know, and we have been talking about since our second session, that our alveoli, when we breathe out, all the air comes out. So what happened? The alveoli get collapsed. Okay, naturally, the nature has given us such a functionality in the lung that it remains little open, so we can have the exchange of air all the time. But for the stiff lungs, for the lungs with the ARDS, this function get affected. So we want to keep the alveoli open all the time. So we give some more pressure to keep those little little air sacs open. This is what we're talking about, PEEP, positive and expiratory pressure. What is the amount of air that remains in the alveoli is our PEEP. And as you have seen that patients with ARDS, especially with COVIDs and all, we keep the PEEP very high because they have difficulty getting that oxygenation or exchange of gases done because of the stiffness in the lungs. So that's why they need more PEEP. The other one is inspiratory expiratory ratio, or very simple, you can call it IE ratio. So as we mentioned, we want to make sure whatever cycle that we are bringing out, if I'm my inspiration cycle is for like 1 second or 1 minute, my expiration goes to 2, like 1 to 2. How much time I want my inspirational cycle to finish, and how much time I want my expiratory cycle to finish, and then the new cycle begin. It's normal to have 1 to 2. Sometimes we can change it as per the patient's situation, because most of the time during the expiration phase, it's still the exchange of gases going on. So you give more time for that exchange, it's better, and we serve the purpose of giving more oxygen to the lungs. Okay. So sometimes when you get the report from the previous slide, please. So when we get the report from our nurses, what they call you, okay, the patient is on volume control ventilation, which is the mode with the rate of 12. That means the ventilator is set for the rate of 12. But remember, patient can still breathe with that, right? And the tidal volume is 500 cc. The FiO2 is 0.9. And then the PEEP is 10. As we all mentioned, that we need more PEEP for ARDS, and the IE ratio is 1 to 2. So these kind of terminologies that you should get familiar to hear from your physician when you are taking care of patients on the ventilators. Next slide, please. Okay, so let's see. While giving handoff report, the nurse mentioned following ventilator settings, like Mrs. N is on volume control with a rate of 12 per minute, tidal volume is 450, PEEP of 8. What other information she's missing? What is missing out in the whole verbiage of ventilator parameters? Is the brand of ventilator that she forgot to tell us? Or the patient was on humidifier, she forgot to tell this, or patient's ABGs, or the fraction of inspired oxygen. And your time begins now.
Shabana, can you see them answering?
No.
Okay. For some reason, I can. So I'll tell you the result.
You got the luxury, sir.
Yeah, cool. So 75% have said fraction of inspired oxygen. 13% have said patient's ABGs, and 6% have given the other two answers each.
Okay, perfectly fine. That's okay. Yes, the nurse missed telling us the fraction of inspired oxygen, FiO2. Yes, the humidification is important, but that has nothing to do with the nursing. It comes with the ventilator. And the ABGs, yes, we go ahead and see the labs, and we sometimes mention that, but right in this verbiage of parameters, FiO2 was missing. So yes, you guys got it correct. Next slide, please.
Cool. Here's the next slide.
Okay, which of the ventilator parameters should be adjusted to maintain the optimum minute ventilation? Now, see, we are talking about the minute ventilation. When we talk about minute ventilation, we talk about what? Tidal volumes, okay? So now think in this perspective. Is this FiO2 and PEEP, which is kind of maintaining our minute volume? Is the tidal volume and the respiratory rate, which is maintaining our minute volume? Is the IE ratio and the respiratory rate, which is maintaining our minute volume, or the tidal volume and FiO2 is maintaining our minute ventilation? Remember, minute ventilation, minute volume.
Okay, we've got the results. 59% have said tidal volume and respiratory rate. Another 27% have said IE ratio and respiratory rate. And the rest of 15% is covered between FiO2 PEEP and TV and FiO2.
Okay, great. Okay, so yes, it is tidal volume and respiratory rate. Remember, we mentioned tidal volume is the amount of air, the volume of air that we want the patient to get in. and the respiration rate. So in one breath, say 500 ml of air goes in the patient's lung. So minute volume is how much we get in the minute. So if a patient is breathing 15 breaths per minute, every breath is getting 500 tidal volume. You multiply it, and that gives you your minute ventilation. Okay, next slide, please. All right, so let's go back to the bedside now. Let's look what Mrs. N is situation is now. So you are assigned to Mrs. N, who is on the ventilator, as we mentioned. Now what should I do? Because I'm not an ICU nurse. I have never taken care of any patient on the ventilator. So fine, that's okay. Take deep breath, okay? The first part is our assessment. Anytime when we go and took care of our patients, it's always start with our assessment. So we all know patients on the ventilator, when you try to assess those patients, it's just the same. There is no difference. Only there is a machine hooked up to those patients. And we have to look for some other safety checks and some other numbers. And what are those? We're gonna go through that. Next slide. All right, this is just a little acronym that I saw online, and I just liked it just to remember. It says VENT, like V for ABGs, view ABGs. E is for evaluate the breath sounds. Very, very, very important for the patient who is on the ventilator. N is the notice a GI complication, as Dr. Kalim just mentioned. One of the complications is about the ulcers because patient's body is going into stress. And T is the 20% can be weaned. So you have to wean it slowly. And this is something very important to know. If you want to wean down a patient from FiO2 or from PEEP, always go slow. Don't go like, if patient was an 80% FiO2, turn down to 60%, 40%. No, just go very slow. 10 to 15 it's the best way. Otherwise, you will be tagged with the ventilator associate events. So this is just a little bit acronym to note, but we'll be going into details of all those things. Okay, next slide. All right, so the nursing assessment. Okay, so the best approach is to perform a head-to-toe assessment, which is fine, but you can always perform a detailed system-wise assessment. Okay, if you talk about neurological assessment, when you look at those patients, you look if the patient is comfortable, if patient is irritable, fighting with the vent, or gasping. Patient with COVID, they require more sedations, more neuromuscular blocking agents, more paralytics. So patients should thoroughly be assessed for any neurosensory function deprivation. The agitation and delirium, because of the environment, there are so many monitors, so much noise, so much of stuff going on. Our lights are on all the time. So that always keeps our sensory perception on a higher side. That makes patient agitated and in delirium. Just reorient the patient. Hey, those patients are still listening to us, so just reorient them. Hey, you are so, hey, Mrs. N, I'm your nurse, and this is the daytime. This is 10 a.m. or 7, whenever you're taking over, 8 a.m. in the morning. I'm your nurse, and today is this so-and-so date and day. It's a bright, sunny day. Just talk to the patient so they know, oh, okay, so now this is the daytime. Oh, it's a nighttime, okay? If patient is agitated, just don't put the restraints. I have seen nurses, the only thing they find out is to restrain the patient when they are agitated. No, try to identify the cause. Is this the sensory stimulation? If patient is in pain, what is the reason patient is so agitated? Now remember, patient is all tied up with so many wires and tubes and everything. So any normal person will be agitated. So how to overcome those things, which is very, very important, okay? The sedation and pain. Do not think that patients are laying down, they are not talking, so they are not in pain. They may be in tremendous pain. There is one whole big tube going from their mouth all the way to the lung, which is quite traumatic. So yeah, they are in pain. So always go and assess for the pain. Assess if patient may need some little light sedation so they can be relaxed, cool, and calm. But don't forget to mention, have we sedated the patient so deeply so now they are not waking up? So there are some scales that we use. The one of them is RAS, And if I could recall, we discussed about a little bit about the RAS in our session 1, when we were doing a head-to-toe assessment, and the presenter did it pretty well. RAS, RASS, is a Richmond Agitation Sedation Scale. And then it has a number. So 0 is the one which is a required number, or -1. More you go in a negative way, the patient is sleeping deeply. Or if you go on a positive side, like +1, +2, +3, patient is more agitated. So these are the tools through which you can monitor and titrate your sedation medications up and down to achieve a level when patient is comfortable and aroused in an arousable state. You can have just a, the visual analog where we have so many faces, like an angry face, sad face, crying face for the pain scale, and patient can always point out what level of pain patient is on, 7, 8, 6, 5, and we can give them some pain medications to calm them down or make them comfortable, which is very, very important. And again, as I say, patient can hear, they feel the touch, they feel the pain, they look sleepy, but they are awake. Okay, so yes, you can give some analgesia, some sedations, but try to avoid NSAIDs, especially if they are COVID patients, because they have increased chances of kidney injuries. And you can just give a simple, you can ask the doctor to give some little midazolam or some Presidex infusion. We will be covering those medications in our later presentations. Sleep is very important. I know the patients are there laying in the bed, eyes closed, can't do anything. But remember, these patients need sleep. They are awake. They are still hearing, and their sensory stimulation is very high. So sometimes administering those sleep medications help, because during the daytime, if they are awake, it's better for them to sleep at night time. So next day when you come, they can work with you on the weaning parameters, working on their breathing pattern. So it's very, very advisable to give them a little bit tranquilizer so they can sleep properly in the night time. The head of bed is very, very important. We have to keep the head of bed always 30 degrees, because these patients are very high risk for aspiration. I'm talking about musculoskeletal area now. Early mobilization is very, very important. As we know, the position is important. These patients cannot turn by themselves. They are very high risk to develop their deep pressure ulcers. We talked about prone position for patients who are on ARDS and they need prone. In our last session, we talked in detail, so I'm not going to talk about it more. For cardiovascular, these patients are high risk for hypotension, because remember, they are going through infection process. They are in shock. They are getting so much of pain medicine. They're getting so much of sedations, analgesia. So as a side effect, these patients have low blood pressure, and sometimes these patients have started on special blood pressure medication, pressors. So you need to be very careful on checking on those blood pressures very frequently to make sure they are not all the way down, or their pressures are on a higher side, so you can titrate those medications. Then due to change in the intrathoracic pressure, the cardiac cycles get affected. So there is an issue in preload and afterload, so that may have the hemodynamics go up and Y, here and Y. Shock, patient, as I say, patient may go in shock because of hemodynamics compromise. Patients are going through infection, so they may develop some septic shock. For pulmonary assessment, very, very important, as I mentioned, the breath sounds. The auscultating for breath sound is very important. And it's just not the auscultation around the lungs, but around the neck area. So by auscultating the neck, you are actually checking the patency of ETT cuff, which is holding the tube in place within the trachea. So if you put your stethoscope on the neck area and you are able to hear sound, like inhalation and exhalation, you should be able to hear normal breath sounds. But if you don't, and if you hear a gurgling sound, that means the cuff is not inflated. Either the cuff needs to be inflated or the cuff has been busted. Every time when you come to take over, you need to check the ETT location, where the ETT is exiting from the teeth or from the lip. What is the number of centimeter that the tube is exiting? Normal, it's 22 to 24, depending on the size of the patient. And then Checking the chest x-ray, the doctors need to check the chest x-ray, and you have to make sure that they are checking the chest x-ray. Sometimes the radiology would call you, hey, the tube is all the way up or tube is all the way down in the carina. So you have to tell the doctors to pull the tube up, to pull the tube down as per the situation in that chest x-ray. And you as a nurse might be helping those doctors or technicians to manipulate those tube up and down. The SpO2, very, very important to know that how the patient is saturating. Remember, for ARDS, the patient with COVID, we are not very optimistic to have the SpO2 of 100%, 99%, and we are happy, hey, my patient saturation is 99. No, if our patient is making up to 91, 92, that's a great achievement for those patients. Because remember, we are talking about more and more lungs compliance, which has been affected in our ARDS, okay? The next one is renal. As we all know, our urine output is very, very important for those patients to monitor. Those patients are most of the time, 90% of the time, they are on Foley catheter, so we can measure the urine output every hourly. With ARDS, and especially with COVID, 35% of the patients that develop acute kidney injury. So it's very important to keep an eye on the urine output. You need to keep an eye on the daily electrolytes, the BUN, the creatinine, and everything. The GI side, this is something I still see my nurses would not give it a priority, but anytime the patient gets intubated, within 24 hours, the patient should start with the tube feeding. Remember, these patients need to be fed. They need protein. How they're going to be recovering? The recovery is not just coming from the medications. They need protein. They need lipids. Very, very important for just like we are normal people. So it's very important to start the tube feeding on those patients. You need to check the residual, all the nursing care that we all know about the tube feeding. We need to make sure they have bowel movements. We don't want to end up in severe constipation, and then we are looking at some kind of obstruction, bowel obstruction later on, because we didn't take care of this part. Liver failure, as the literature is saying, that it is very common that patients with the COVID, they are going in liver shock. So it's important to keep an eye on this part, keep an eye on the liver function test and other lab results. The blood loss is not primarily because there's something going on with the platelets and all, but it's basically because of so much of phlebotomy, so much of blood that we are taking, or if patient develop some stress ulcers, then of course they may start with a GI bleeding. So keep an eye on the CBCs, make sure the hemoglobin is okay, and a patient is not needing more blood. The other one is infection. As we say, that patient is going through a very severe process of infection in the body. So keep an eye on the WBCs. Those patients are on antibiotics sometimes. So is the antibiotics working or not? If patient is having fever, these patients are with the Foley catheter, which itself carries a high risk of infection. These patients are with the central lines. So central lines itself bring a lot of infection in the body. I'm talking about Klebsiella and CARTI, which I'm going to be covering later. So yes, so it's very important to keep an eye on those trends. The other is endocrinology, blood sugar. You see, our body is going through a stress process. During stress, our sugars go high. Sometimes those patients are put on steroids. So all these things increase our blood sugar level. So you should not be surprised to see a COVID patient being on insulin drip. That's as Mrs. N. Remember, Mrs. N, when she came in, how much her sugar was? Above 600, I guess. So we had to start her on insulin therapy. So that's why, because our body is going through a stress process. Dermatology, we know pressure ulcer, very important. Those patients are just laying down, doing nothing. They are dependent on nurses, on our care. So turning the patient, especially the area where there is an OETT by the lip side or mouth side underneath, they develop the skin get very affected. You should not be surprised to see the pressure sores around. Pressure sores are not just at the back area. Pressure sores could be on the ear. When we are turning the patient, those air at the back of the ear, they may get pressure sore around just the neck area, around the beneath the ETT, beneath our Foley catheter. So all these, wherever there is a pressure due to the friction, due to bed, due to any device, they may end up in giving the ulcers. So always check your skin for that. Next slide, please.
Shabana, we have 5 minutes left.
Okay, so this is the overall plan of our patient care, that we have to provide the effective breathing pattern. We need to improve the gas exchange. We want the body to get every need met in pulmonary wise. So I think we have covered this already. So next slide, please. All right, so just I'm going to cover very briefly about the troubleshooting on the ventilator. And if you see on this picture number 1, that is the pink ventilator, okay, the machine, and that machine is it's connected to the patient lungs, which is the yellow thing with the tubes. So any troubleshooting will come from these 3 parts, either from the ventilator, either from the tube, or either from the patient side. Okay, next slide. So when we talk about high pressure alarm, that means it could be because of the patient, could be from ETT, could be from pressure related. So when patient is biting the tube, patient has the secretion all around the ETT, that's why it's been alarming, or we have given too much of pressure in the lungs, that's why the ventilator is alarming. Okay, low pressure alarms, every alarm which is low, that means there is some leaking going on in the ET side or on the whole circuit side, the cuff is busted, the cuff is leaking. So those are very common alarms. And then it comes the apnea alarm. The apnea alarm, patient is not breathing at all, either the ventilator has shut off, either the patient is not breathing, or the ventilator parameters are too low that's not affecting the patient. So all the high alarm are related to our tubings on our patients most of the time, the ventilator, and the low is always related to leaking side, that something is going out of the system. Next slide. So what is the best care that we can do? Always assess the patient. Whenever the ventilator is alarming, go ahead and assess the patient. We have tendency to look at the ventilator screen first, but always see the patient. If patient is breathing, if patient is not breathing, patient is in distress, disconnect the ventilator, start bagging the patient. Okay, the bag valve mask should always be there in the patient's room. See if patient needs suction, if patient needs any medications to cool down, calm down, maybe he needs some medication. And then if patient develops some pneumothorax because of the pressure, patient may need the chest tube insertion. So as a nurse, it is very important for you to know what are the supplies that needed for the emergent chest tube insertion. And if the tube is out, patient has extubated himself, how to reintubate. Of course, you will not be reintubating, but you should be knowing what are the things needed, and those things should be there in the patient's room, just in case patient get extubated by himself and you need to reintubate the patient right away. Next slide, please. So these are important bundles. Those are important care that we have covered over while I was talking to you about the hand washing, oral hygiene, very important. We have to keep on checking the closed system of the ventilator, skin care, position, daily sedation interruption to see if patient is too sleepy or too much awake. Nutrition therapy that we should start right away. If patient is on Foley care, the cleaning, making sure he's not developing any infection from there, the central line care, daily assessment, daily checking if it's red, or if there is you need to remove these devices should be removed as soon as possible. The chlorhexidine bath, which is very important, the CHG bath, the one with the antiseptic, that to minimize the chances of infection of those patients. And then emergency supplies, as I mentioned, always make sure you have an ambo bag ready in the bag in the patient's room working. Suction should be in the patient's room until you get all the supplies gathered, and until the doctor comes, at least you can just go ahead and bag the patients just in case patient is extubated. Next slide. So this is another acronym, DOPES, like check for displacement, if the tube has been displaced up and down, or if there is an obstruction, any secretion, is there a pneumothorax, if there is an air around the chest cavity, the equipment is functioning well, or if patient is not taking good breath or more breath or less breath. Next slide. Next slide. Can I have next slide, please? Yes, and this is something one of Dr. Noor Kabani shared with me, that she always worked with her nurses by this acronym, FAST hugs, BID. I know this is not the time we can hug each other, but just a virtual hug, okay? FAST, F is for feeding, start the feeding right away. A, analgesia. S is for sedation, if patient needs any sedation. All prophylaxis, like any VTEs, SCDs, that should be on the patients for the VTE prophylaxis. For the hugs, H is for head of bed, always 30 degrees, unless the pressures are on a lower side. U is for ulcers, C is for glycemic control, and S for SBT trial, like spontaneous breathing trial, to see if patient can initiate breaths on her own while remain intubated. And the BID is B for bowel regimen, I is for indwelling catheters, and D is to de-escalation of antibiotics. If antibiotics are no more needed or they have finished their cycle, we should just discontinue that and do not keep on continued. Next slide. So almost end. So this is a question. After taking over, the nurse enters Mrs. N's room, and after her assessment, she ensured the head of bed is elevated, check. She suctioned the ED, check, and she did the oral care. So what these interventions are significant for? She's trying to prevent the line infection. She's trying to prevent the fever. She's trying to prevent the ventilator-associated pneumonia, or she is trying to prevent the pulmonary complications due to ventilator.
Okay, then. So it looks like 40% think it's ventilator-associated pneumonia, and 40% think it's pulmonary complications due to a ventilator, and 20% think it's line-associated infection.
Okay, I would take the 3 and 4 more. Yes, it's specifically for ventilator-associated pneumonia, but on a general, yes, you can say it's a pulmonary complication, because VAP or VAM, ventilator-associated pneumonia, is one of the complications. So for those who have marked 3 and 4, I will give you a point. Next slide. So on lung auscultation, a nurse could not hear lung sound on the chest area. She hears a gurgling sound when she put her stethoscope around the neck region. What does that mean? Patient is just breathing by herself. There's a leak, either the cuff or the ET tube on the ventilator tube. There's a leak happen, high pressure in the tube, or there is a problem with the humidification.
Alhamdulillah. Okay, we have got the results, and it looks like 87% people think it's cuff leak.
Okay, I made my day.
Yes, and 13% think it's patient is breathing by herself.
Great. Okay, you got it. You can take care of the patient now. Next slide. That's correct. Next slide. Next slide. All right, so just a summary. It's just, you need to understand what mode of patient is on at this time. You know how to auscultate the breath sound, how the patients, what are the patient's parameters. And remember, there is no such mode. You can say this is the best mode, this is the only mode the patient will be recovered. No, different patient gives you different results. And the nursing care is always the same as we do for any patient, with this exception of we have to look at some of the numbers and the parameters on the ventilator. Thank you so much for listening.
Okay.
Hi, thank you, Shabana, and thank you, Dr. Kalim. It was wonderful to hear both of you. Just a reminder for everyone, we are back next week. This patient's journey will continue, and the focus next week is very much going to be the medications which are being given to the patient to keep her hemodynamically stable, to feed her, and to make sure that she can survive through this period of being ventilated. There is just a reminder, Dr. Kabani, do you want to mention about the critical care nursing course before we say goodbye?
Sure. I don't know if we are ready to kind of go into the
probably next time
details.
then.
But yeah, I think next time, plus we've run way over time. I wanted to remind everyone to fill out the feedback forms. There are some very good questions in the Q&A. Dr. Kalim was ready to answer them, but I think we are running over time and beginning to lose some participants. So Dr. Kalim, if you'll be here next week, we can maybe answer those questions. Would you be kind enough to join us? Okay. So I think that would be better. So we have everybody here.
In that case, thank you everyone for joining us. Thank you, Dr. Kalim again. Thank you, Shabana, and thank you, Dr. Noormahal, for helping us out. And I would say goodbye.
Thank you. Bye.
Take care. So.